So we'll continue prostate cancer part 8 because there's still likelihood of cancer when even when the repeat multiparametric MRI show that the lesion has improved to BIRA DS 2 or 3, the risk of finding cancer on repeat biopsy is nearly 25%. So if the repeated multiparametric MRI show that the lesion is still BIRADS 4 or 5, then the risk of finding cancer on repeat biopsy is 62%. A molecular test for details on this test, BCS3, it is molecular test BCS3A that's analyze urine for overexpression of the BCS3 gene from the cancer cell or prostate cancer. So BCS3 is FDA approved to determine the risk of the cancer in men age more than or equal 50 with a previous benign prostate biopsies. Tests for tumor field effect cancer can induce change in the surrounding benign tissue. These changes are called field effect or halo. When a benign core contains a field effect, there is a high risk of cancer elsewhere in the prostate. If this is a suspicion of the prostate cancer despite previous benign biopsy, then testing for a field effect can help to determine the risk that cancer may be present. Examples of the tests that check for a field effect include confirmed MDX and prostate core mitotic test. So we come here to the side effects of the prostate biopsy. Most side effects are minor, major side effects are rare. So severe rectal bleeding. This is initially managed by applying pressure on the prostate, pressure to the prostate using one of the following methods. Hold pressure with finger or with the ultrasound probe. Rectal bag, place a lubricant bag in the rectum, place a Foley catheter in the rectum and inflate the balloon, often done after rectal bag or packaging. If bleeding persists despite holding pressure, considering applying hemostatic agent, anoscopy with suture ligation or colonoscopy with injection of epinephrine. If bleeding still persists, embolization or surgical intervention may be required. Severe gross hematuria, especially with clot retention, is initially managed by placement of the urethral catheter and irrigation of the catheter to remove the clots. Placing catheter on a light traction for a short period of time may help stop the bleeding. If significant bleeding still persists, then start continued bladder irrigation using a three-way catheter. If bleeding still persists or warrants more immediate intervention, then perform cystoscopy with coagulation of bleeding sites. Tumor seeding along the needle track is extremely rare. Only 40 cases were reported from 1953 to 2012. So only 40 cases. The majority of the cases presented with high-grade, poorly differentiated cancer. This is a prostate biopsy side effect, and this is the risk. Minor gross hematuria common, minor rectal bleeding common, hematospermia is common. This is the three more common. Minor gross hematuria and minor rectal bleeding is common, and hematospermia is also common. Bleeding require intervention 0.7%. In transient fever is less than or equal 6.2%. Epididymitis 0.7%, prostatitis 1%, sepsis and vasovagal episodes, and avoiding symptom transient less than or equal to 55%, urinary retention less than or equal to 2.6%, erectile dysfunction less than 1%. This is the management biopsy result. Prostate biopsy performed normal or AAH or um, low grade atypical adenomatous hyperplasia or low grade BIN and or focal high grades. So monitor PSA and get a rectal examination. Prostate biopsy performed and show multifocal high grade BIN more than or equals 3 sites. Monitor PSA and digital rectal and extend rebiopsy in 1 to 3 years. If sub or atypically small acinar proliferation or suspicious for cancer, extended rebiopsy in 3 to 6 months. If prostate cancer stage and management. So prostate intraepithelial neoplasia. This is the BIN, high grade BIN, low grade BIN. High grade BIN, we will do monitor PSA and digital rectal examination and extend rebiopsy in 1 to 3 years. Normal or atypical adenomatous hyperplasia or focal high grade BIN, we will do monitor PSA. If high grade BIN, not focal, we will do extend rebiopsy in 1 to 3 years.